So I'd like to introduce our presenters today. The first will be Dr. Harold Adams. He is a professor of neurology in the Carver College of Medicine at the University of Iowa. He has been active in patient care and clinical research that has focused on the diagnosis and treatment of vascular diseases of the brain. Dr. Adams was one of the developers of the NIH stroke scale and the leader of the development of the TOAST classification, two important advances in stroke research and patient care. His scholarly activities have resulted in approximately 500 publications. He initiated the writing of guidelines for the treatment of stroke and has served as chair of the Stroke Council of the American Heart Association and the chair of the advisory committee of the American Stroke Association. In addition, Dr. Adams was a director of the American Board of Psychiatry and Neurology and led efforts in creating the subspecialty of vascular neurology. Next, we have Dr. Jeremy Shefner, who is chair of the Department of Neurology, professor of neurology, and senior vice president of Barrow Neurological Institute. Dr. Shefner's research focuses on biomarker development and the clinical therapeutics of ALS and spinal muscular atrophy. He co-founded the Northeast ALS Clinical Trials Consortium, the largest and most active consortium in the world dedicated to ALS. Dr. Shefner has published approximately 200 papers in peer-reviewed journals and has served on multiple grant review panels. He also participated in committees organized by the Institute of Medicine to investigate the relationship between military service and ALS, as well as the health effects of Agent Orange on Vietnam War veterans. And in 2014, Dr. Shefner received the Sheila S.E. Award for ALS research, presented annually by the American Academy of Neurology and the ALS Association. So I would like to thank both of our distinguished presenters today for their time and presentations. Dr. Adams will start us off, and then Dr. Shefner will follow.
Thank you, Joy, for the introduction and the invitation. We're going to divide this hour into two roughly 30-minute blocks. The first is going to be on clinical outcome scales that I will present. I have no conflicts of interest, and there's no real therapy discussed today, so hopefully you keep all of us out of trouble. Sometimes I wish I had some disclosures, but I don't. Let's go on. Now, outcome measures are an important component of any clinical trial. These are going to be selected carefully by the investigators. There are surrogate outcome measures. Dr. Shefner will talk about those in a few minutes, and there are clinical outcome measures. For this presentation, I'm going to use clinical research in stroke as a model, but the same things are going to be true for all types of neurologic diseases. When I was on the FDA advisory panel that approved TPA, we looked at clinical outcome measures as being the primary measure of success. In fact, overall, we want to know how the patient is done as an outcome measure, as the primary outcome measure. Next. So there are terms for outcomes that we will use. There are some terms that you need to become aware of in all clinical research. Impairment, which is the nature of the neurologic impairments found by examination. Handicap or activity limitations, those effects that hamper the patient's independence. And then disability, which is, or participation restriction, is the term that describes the person's role in society. These are not synonymous. I give the example of two musicians go out to do some work in a wood shop, and both cut off their right hand. One is the vocalist. Obviously, he has an impairment, but he is not disabled, while the pianist is. So it depends on what the patient's own activities are. Obviously, mortality, quality of life, healthcare costs are important. For trials that are trying to prevent new events such as many stroke trials, recurrent events, and then, of course, adverse events that are tied in with the disease or the intervention. Now, in stroke, there are surrogate markers, such as imaging, determining the size, location, and evolution of a stroke, recanalization, which has become quite popular in the trials of endovascular therapy, maybe biomarkers that can be used, but currently in stroke, no surrogate marker has gained acceptance as the primary outcome measure. If we do successful recanalization, but the patient is not better, that still is not a success. So at least in stroke, clinical outcomes will remain the primary measure. I would argue that's going to be true in almost all areas of neurologic research. Now, there are issues in design of clinical trials in ischemic stroke. These are similar in other types of neurologic disease. We have a broad spectrum of vascular disease. We have wide variations in the extent and locations of the brain injuries. There may be epidemiological variables or comorbid diseases that influences treatment. We have multiple concomitant therapies, such as best medical care. And the treatment goals and the nature of the intervention may have specific issues that need to be resolved. For example, in the trials of thrombolysis, bleeding complications became a very important measure of safety. Similarly, with the endovascular trials, looking at successful recanalization became an important measure of success. Now, clinical rating instruments such as stroke scales are a fundamental component of clinical research. Now, what is of interest is when we developed these scales back 20, 30 years ago, they have now gone into clinical practice so that you will find guidelines describe, for example, what the severity of stroke is as defined by the NIH stroke scale or level of consciousness by the Glasgow Coma scale. These can be used at baseline, at whatever the intervention is, and then are going to be used to changes in neurologic status. These will affect decisions about both acute and long-term management and will look at responses to treatment. The same process, whether it's in stroke or Parkinson's disease, will be using the same concept for the clinical rating instruments. Now, how do you select a useful clinical rating instrument? It must have inherent validity. It has to be germane to the clinical situation. It needs to be clinically useful and therefore widely used. In short, any clinical rating instrument needs to make sense to both healthcare providers and the public. In short, it has to be understandable. If you, those of you who may have been involved with stroke during your training or in your research now, if you get somebody who says a patient has an NIH stroke scale score of 3, you have a mental image of that patient. Conversely, if you see a patient who has an NIH stroke scale score of 25, that's an entirely different sort of situation. In the first case, the patient is sick. In the second case, the patient is really sick. And you will have an image as to what that patient looks like. That's what's good about rating instruments and good scales. Now, if you decide you want to develop a scale, it's a complex process. You have to decide what the purpose of the scale is and what the information is to be gained. You need to know that it is relevant to the assessment of patients. Generally, a scale is based on the patient's performance, on the examination. Occasionally, some scales will have history and examination, but you really need to define what items are only going to be by history or what items are going to be by examination. The more variable sources of information for the scale, the more difficult the scale will become. You do not want to have imaging, history, examination all thrown together into one scale because it becomes very hard to understand how the points or how the final score is determined. You want to see how the new scale will work in relationship to other rating instruments. Are we on the same path or have we gone off track? Now, what are the attributes of a useful clinical rating instrument? It should be easy for both patients and assessors. It cannot become a burden. It cannot take a long time. There's an excellent scale the physical therapists use that takes 45 minutes. We tried it on our patients at Iowa. It's called the Fugelmeyer score. Both the study coordinators and the patients threw up their hands because it took far too long. They didn't want to do it a second or a third time. Performance and scoring must be straightforward. You have to define what each of the items on the scale is and how it is scored. And there has to be a real cookbook for this. Then the scale needs to be tested for reliability and reproducibility. Does the same rater give the same score when the same scenario or similar scenario is brought forward? Do two or more raters generally give the same score? And then, of course, for clinical trials, we have to do educational and certification programs. You want to know that a scale being assessed in Phoenix is going to be done basically the same way as in Iowa City or Ann Arbor. Next slide. Now, this means the extra requirements for all of us who are doing clinical research. This is especially true for multi-center clinical trials. It needs to be sure that the scale is being administered correctly and that the scoring is accurate and consistent. Thus, I would encourage you in your research projects to use validated scales. So one of the reasons is that then your data can be compared to those from other research programs. And even more important, funding agencies and regulators will look at your scales. Once again, I've already mentioned programs to improve reliability and reproducibility. One of these is a central adjudication, where one group of investigators looks at all the data in detail. Now, what is the general organization of a clinical rating instrument? One thing before I want to take a step back. Please, in your development of your research projects this year, do not come up with the idea to develop your own unique special rating instrument for your patients. This will not get you anywhere other than behind. You will have too many steps. It's a dead end, so please do not do it. Now, the general organization, as I mentioned earlier, is going to be based on history and direct examination. Generally, there are two types of scales: a numerical scale, which adds total of scoring of several components of the assessment, and a single score scale based on aggregation of all information rather than scoring individual items. Both of these are used in neurologic research and will be specific for the disease that you are testing the intervention. Now, in numerical scales, several items are assessed and scored independently. These scores are then added to give a total score. The total score may represent a different combination of items. Depending on the organization of the scale, a high score can be good or it can be bad. For example, the NIH stroke scale is a numerical scale that ranges from 0 to 42. And in the NIH stroke scale, the higher the score, the poorer the outcome. I tell patients and families that the NIH stroke scale score is like golf. You want a low score. So when we developed the NIH stroke scale back 30 years ago, we did initial testing to prove inter-rater agreement and test to retest reliability, which, as you can see, the kappa scores are quite good. This was the first scale in stroke that really went through this sort of testing process. We then compared it to the size of the infarctions on CT and outcomes at 3 months and found that we did very well. It was then subsequently tested in several other groups and now is used internationally in a wide range of stroke research. So the NIH stroke scale went through a couple-year process of being developed, tested, modified. There were things that we put in as we developed it, things that we took out. We had pupillary responses in there. Initially, we found that that really didn't help. We had reflexes in there initially. That was taken out. We added things in because we found out that we needed to refine it in more detail. So this is a process that takes time to develop a scale that has validity, like the NIH stroke scale. Now, what else did we do for research? We did a research process using videotapes. By the way, these videotapes are still available. And we went through for education, testing. We remediated those investigators that did not do well. We test reliability. We found that there were two components of the NIH stroke scale assessment that was hard to certify, to get high rater agreement on. One was on facial weakness, because a lot of smiles were thought to be abnormal when in fact they weren't, and ataxia. So both the NIH trial that tested TPA and the trial that we did testing anticoagulation both did this certification process in the beginning. On the public, there was a development of the National Stroke Association certification process, which was once again found that facial weakness, but this time language, were problems. And they found that people who did it multiple times did not seem to learn. But still, all these steps were taken to show that the NIH stroke scale was useful in evaluation of patients. So what are the advantages of the NIH stroke scale in acute stroke research? It's a validated measure of stroke severity. It can be performed by a wide range of healthcare professionals, nurses, physicians, medical students, residents, EMTs. There's a good correlation with outcomes, and it can be used for planning both acute and long-term care. We know that the prognosis of a patient for favorable outcome is extremely high if the baseline score is under 5. We know that if they have a score of 15 above, they have a very poor prognosis. We know that between 5 and 15, the likelihood of a favorable outcome drops approximately 5% for every point that is added. We also know that with a score of 20 or greater, that the patients have less than a 3% chance of a favorable outcome without treatment. These are all very robust data. In fact, the NIH stroke scale score is the single most important predictor of outcome after stroke. We've already shown that it is high inter-rater agreement and inter-rater reproducibility. We've adapted it for multiple languages and cultures. And of course, we can do this by telemedicine. I've done it. And there are educational and certification programs for this. Now, there are disadvantages of the NIH stroke scale. With similarly sized lesions in the right and left hemisphere, scores are augmented in the left hemisphere, largely because of the effects of language. There is some disagreement in scores among raters, but still there's moderate to excellent agreement in most items except for the 3 that we've talked about before: limb ataxia, facial paresis, and aphasia. I wish we had not put limb ataxia in. We put that in for cerebellar infarcts, but a lot of raters forget that patients with paresis have paresis and may have secondary limb incoordination. So now, what about the current status of the NIH stroke scale? There have been attempts to modify it, but still the original scale remains the standard. It is the most widely used clinical research tool in stroke research and in clinical care. National guidelines use the NIH stroke scale. It's the entry criterion for trials and selection of innovations. It is used in interphysician communications. I do not see, for example, the NIH stroke scale to be replaced in the near future. And all stroke doctors need to become proficient in its use. So if you're going to do a stroke research project, this will be basically a mandatory component of your study. Now, what about global outcome measures? These scales are also widely accepted by the medical community and generally differentiate favorable from unfavorable outcomes. These can be used in a variety of trials in stroke and in other types of neurologic disease. They measure the impact of multiple neurologic impairments or disabilities in the patient's overall status. Now, while these are very helpful, they may miss important neurological problems. They may overemphasize some components of recovery, and they may have ceiling and floor effects. The modified Rankin scale has both ceiling and floor effects, for example, and these often require larger clinical trials to determine success. Now, one of the ways that we've gotten around, at least in stroke, is developing different strategies to compare outcomes. Now, what happens with a single score like this is that all components of the assessment are summarized, as I mentioned before, in a singular score. And in effect, they separate the good outcomes from the bad outcomes, from the really ugly outcomes. Each score will have a specific and defined criteria. Generally, the higher the score, the poorer the patient's situation. A classic example of a single score in stroke is the modified Rankin scale. Now, the modified Rankin scale is a global outcome scale that is internationally accepted and used in a wide variety of stroke studies. Information about the status of the patient with an emphasis on motor limitations in walking is the fundamental component of the scale. Once again, it can be provided by, can be done by a broad spectrum of healthcare providers. The different scores, levels of recovery are understood by physicians, insurance companies, disability raters, and governmental bodies such as the FDA. Next slide. Now, in addition to the global measures like the Rankin scale, there are modality-specific scales for recovery after stroke, and depending on your research project, there may be a modality-specific outcome measure that you want to use as your primary hypothesis. This will evaluate responses to an intervention aimed at the specific impairment or disability. While these are used in rehabilitation research, they are also now being used in recovery research. This could be a pharmacologic agent, it could be a device, it could be some other local intervention. And so it aims at the recovery of some neurological impairments or the halting or worsening of some neurological dependence. And this can be done from a much smaller number of subjects to get data. Now, probably a couple of limitations are it may not give you much information about the patient's overall outcome because of the diversity of neurologic problems. They may not be well understood by clinicians or the public, and the results may therefore not be widely accepted. In addition, your scale and your results may not be able to be compared with other clinical studies. Next slide. Well, examples of these are the Montreal Cognitive Assessment to test cognitive impairments with brain disease. This can be done with stroke, but also is widely used in dementia research. It requires some widely used neuropsychology testing, and it such as the trail making test, and it takes about 10 minutes to do by direct observation. While this study has not been extensively tested in stroke, it is being used in a broad spectrum of diseases that affect cognition. The Center for Epidemiological Studies has come up with a scale to test depression. This is very common after stroke, and depression is associated with worsening outcomes. So there are now these scales that can be done with the higher scores associated with more severe depression. Quality of life measures are used in a wide variety of neurological research studies. These cover functioning physical activities, psychological, social, and general health experiences. And these are greatly influenced by the patient's own environment. These are generally not the primary way to measure success of treatment, but scales such as the Euroqual and the stroke impact scale are available. The Euroqual is a very simple test where you ask 3 grades of 5 dimensions on mobility self-care as defined, with no problems, moderate problems, severe, and then the patient is given a strip from 0 being doing really awful to 1 being doing 100 to do very well, and they're just asked to mark where they think they are. This is being used in a wide variety of neurologic research programs. The stroke impact scale, which was developed here in the United States, basically has the same idea of looking at multiple domains of recovery and rating points accordingly, and then, of course, adding the total points up. So what about what scales should be used? For stroke, the FDA and the NINDS have come up with some recommendations. In short, you must use these scales. For neurologic impairment, the NIH stroke scale. For functional status, you can use the Barthel index or the modified Rankin scale. For cognitive things, it's the depression, Montreal cognitive assessment. For quality of life, it's the Euroqual. For performance, you can also do the 6-minute walking test. So there are a wide range of clinical scales to use in neurologic research. I have used the example of stroke, but the parallel things can be found in all areas of neurology. Pick the scales and the outcomes that you want to use based on the value of the scale, whether it is internally strong enough and is reproducible. The choice of scales will also be aimed at the primary aims of the research: acute versus long-term, the duration of follow-up, the nature of the intervention, and the primary hypothesis. Does the intervention change the progression of the disease? Does it improve favorable outcomes? Does it have an effect related to adverse events related to the intervention or not? And then new comorbid events or new events that may be important. Trials, and that includes these pilot studies, must assure accuracy of the clinical assessments. As you can see here, we're talking about how you select patients, how you will follow them, what will be the endpoints and outcomes. Be sure that everybody who's participating in the study has a good idea about the scales. If necessary, certify them. Come up with central assessments of the outcomes. This can be by videos, telephone, in person. And then, if necessary, you may need to have a program to adjudicate endpoints and outcomes. So in conclusion, these outcome scales provide a quantitative element to a complex clinical situation. None of them are perfect, but they will foster communication, and the results of research are being used to describe these. Both you and the clinicians who may see your patients subsequently should have an understanding of the information conveyed by the results of these scales. And I thank you for your time. Are we going to do questions now or later?
Does anyone have any questions or comments before we have Dr. Shefner start with his presentation?
What happened? We need to get back and go back to blue.
Can I ask a question?
Sure.
Of course.
Hi, my name is Ofer. One question regarding the scales and whatnot. I absolutely see your point. My question is in kind of more of a preliminary trial, phase 1 or maybe phase 2 for a new intervention. Do you still think that the clinical outcome like the NHSS should be the primary outcome, even though it's, you're not really sure that this is going to work or not, or whether in this earlier phase trials you should follow a biomarker.
Well, I would argue while you can file a biomarker and it may be important, still you need to have some clinical outcome measure because that's what your colleagues are going to want to have. Now, it can be the NIH stroke scale score showing improvement or worsening. It could be the modified Rankin scale. But in a preliminary study, the first thing you want to know is whether or not your intervention is safe. And so you may want to find out if it has no safety issues, that's fine. But otherwise, your first question is this new intervention safe? Second is, can we identify those patients that might respond to the intervention? And that's going to be, at some point, it has to be clinical. So I would encourage you to have some sort of a clinical outcome measure, because right now, biomarkers in stroke have not been completely accepted. If the patients may have smaller lesions on MRI, but the clinical outcome is the same, that's not going to create much enthusiasm by our colleagues to treat patients with that. Did that answer your question, Doctor?
Yes, it did. Thank you so much.
We have one more question. Is there a place online where we can find guidance from NINDS on recommended or accepted outcome measures in varying disease processes?
Yes, there are. If you go to the NIH, and I don't have the website right before me, but there is a list for diseases, what they recommend as outcome measures. I showed you the whole list for stroke. There are similar lists for other neurologic diseases. And I would encourage you to go to the website and try to use them as much as possible.
And this is Jeremy Shefner. I'm not going to talk about this in detail, but the NIH has spent a lot of time forming what are called common data elements. So for every disease, not only are there outcome measures that are listed, but there are standard ways of performing them, standard ways of scoring them, and they're all accessible on the NIH website.
In short, what Dr. Shefner and I are both saying is, don't go back to rediscover the wheel. Stick with the things that are available, because this is what you're going to need to have if you're going to apply for funded research from NIH and what our colleagues in the field expect you to use.
Great. Thank you very much, Dr. Adams. Dr. Shefner, do you want to share your slides now?
Sure. All right. Do you see them?
Yes.
Okay. Well, hello, everybody, and thanks to Dr. Adams for a great talk. What I'm going to say is pretty much going to sort of merge nicely with his. The only thing I would say is that it might be a little bit different in terms of point of view, is that without question, if you're thinking of doing a middle or late phase trial and you're thinking about looking at clinical outcome measures, it's not only unsafe, it's completely inappropriate to use measures that are new or not unvalidated. But one of the lacks of clinical investigation in all fields of neurology and much of medicine in the last almost 100 years is really a lack of intermediate stage markers, of markers of target engagement, of target of some sort of activation of the system that you need to impact, and that's where a lot of creativity needs to occur still. So I'm going to talk about that. So the title of my talk is Biomarkers and Outcome Measures, and so here are my disclosures. None of them are relevant to either the markers that I'll be discussing or the drugs that I'll be using as examples. So people use the word biomarker all the time, and so it's worth stopping to see what really, what do people mean when they say that. So going to the source of all information, Wikipedia says that a biomarker is a measurable indicator of some biologic state or condition, which means that it can be a measure of what a drug does or what a disease does. It can be either one. NIH defines a biomarker as a characteristic that's objectively measured and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacologic responses or interventions. And so again, that really fleshes out the Wikipedia definition, but says the same thing. But what both of those definitions imply is that anything that one measures in a clinical trial or even in a clinical encounter is a biomarker. And so the term itself loses a lot of meaning in the sense that it's so broad that it encompasses everything we do as physicians. And so I'll try not to use this term too much and talk about specific ways of assessing diseases or responses to therapies. So under the categories of biomarkers that I'm going to be discussing, a huge one is a marker that assesses whether your therapeutic agent engages a target. So in order to do this, you have to have a target in mind, which for many diseases in neurology has been difficult. In my own field, ALS, we've had very few specific targets that we were able to measure engagement for. Another name for this kind of a marker is a pharmacodynamic marker, which has a little bit broader purview, but certainly also includes target engagement. A pharmacokinetic marker is simply a measure of where your agent goes. Certainly you'd love to be able to measure with pharmacokinetics that the drug reaches the intended site of action, but oftentimes we can't do that. For example, if we're looking at a neurologic therapeutic, we can certainly measure presence and time course of the drug in the cerebrospinal fluid, but it's not always easy to measure whether the drug gets into the brain parenchyma. Methods such as PET can be used for this, but they're expensive, they're not always reliable, and the appropriate PET ligand to determine that a drug reaches its site of action is not always available. Pharmacodynamic markers are also target engagement markers, but they are also intended to determine that your drug or biologic has the intended effect on the intended target. So not only that it reaches its target and that it interacts with its target, but that it changes the activity of the target in a way that you think is possibly beneficial. Markers can also be used to identify different disease processes and disease characteristics. So a marker that's a diagnostic marker can be used to more sensitively ascertain diagnosis, or it can be used to stratify populations according to certain aspects of the disease. And then disease outcome markers are the kinds of things that Dr. Adams was talking about more specifically. So functional rating scales can certainly be a disease outcome measure. If your disease causes weakness, assessing strength can be a disease outcome measure. Survival can be a disease outcome measure, and we'll talk about many of these in the next few slides. And then finally, Dr. Adams mentioned that in early phase studies and really throughout clinical investigation, safety is always measured. And so it can't be measured in an unorganized way. You have to have specific aspects of safety that relate to both the disease that you're studying and the potential toxicity of your drug. So where do you use these markers in a development strategy? And so at the top is sort of the general sequence of investigation in drugs. So you use preclinical science to define a lead optimization. So you have multiple chemicals of activity, and you pick or modify those chemicals to become as drug-like as you possibly can. And you certainly do that before you ever give that to a human. Phase 0 studies are becoming increasingly interesting in cancer. They have to do with giving subpharmacologic doses of usually a cancer chemotherapy or biologic, and then after surgery, identifying whether that agent actually has targeted the right places in the brain that you've removed. It's not commonly used in other kinds of clinical investigation. Phase 1 trials are primarily safety trials, although more and more pharmacodynamic markers are being incorporated into those trials. Phase 2 trials are trials where you learn more about dose, scheduling, potential activity of the drug. And then phase 3 trials are your trials where you're intending to file for FDA approval if you meet your endpoint. And those outcome measures that you use in phase 3 are always going to be clinically relevant outcomes. And so below that shows where you would think about different outcome measures. Certainly, you think about mechanism of action all the way through. And so in phase 1, you certainly think about measuring the mechanism of action with your pharmacodynamic marker. You need to gather as much information about where your drug goes. Does it get to the hypothesized target? How is it excreted or eliminated? And those are questions that are usually really it's first addressed in phase 1, but really addressed all the way through clinical investigation. And then disease stratification is something that you think about later when you've learned as much as you can about safety and mechanism of action and target engagement. Then you want to know, can you divide your patients up into those who potentially are more or less sensitive, and design your inclusion criteria appropriately, or at least stratify your trial so that equal numbers of specific disease types are present in all groups. And then your disease progression endpoints or markers are going to be the phase 2 and phase 3 studies, phase 2 and phase 3 functional markers that are in part are encompassed by functional rating scales. And safety is clearly the province of all phases of clinical investigation. Just some examples of what pharmacodynamic markers can encompass. They can be fluids, so you can look at RNA, you can look at DNA, you can look at proteins, you can look at metabolites, all with the intention of seeing whether your drug modifies the fluid markers in its intended fashion. Pharmacodynamic markers can be imaging markers as well. PET can be very specific. MRI and CT are usually more general. In different disease states, physiology can be very important. We now have measures that can non-invasively look at both cortical and peripheral axon excitability, and that actually can be very important in diseases such as ALS or epilepsy, or a variety of disease states where abnormal firing is a factor in the disease. And so the use of these things are to initially test the biological hypothesis that your drug has the activity that's intended. And then often before you get to a late stage where you're using functional markers, you use these kinds of markers to select a potential range of doses that may be efficacious, and to also keep yourself in a safe range. So here's an example of a pharmacodynamic marker in ALS. As you probably know, about 10% of patients with ALS have a specific gene mutation, and about 20% of those people have a point mutation in a gene called superoxide dismutase. This is a gain of function mechanism, so that what is produced is a toxic protein that aggregates in affected cells and serves as a site of toxicity. And so a likely very exciting approach is to potentially reduce the activity of the mutant SOD1 to reduce the amount of SOD1 protein that's produced. And so antisense oligonucleotides have been used for this purpose. They've been shown in experimental animals to reduce SOD1 and have been used in phase 1 studies in normal human volunteers, in normal human volunteers, and in patients with SOD1 mediated ALS to see whether SOD1 can be knocked down. And so here are some data showing that in fact that happens. This is SOD1 measured in the CSF in mutant rats with the transgene for ALS. And you can see that saline does not knock down SOD1, but the antisense oligo knocks it down by about 35% in the brain and about 38% in the CSF, and that the amount of CSF decrease is very well correlated to the amount of brain decrease. So here's a pharmacodynamic marker that your drug is doing what it's supposed to do. This is just measurements of SOD1 in CSF in untreated ALS patients over time. And you can see that this marker has an attribute that may be very useful in terms of a clinical trial. And that is that over time, it's quite stable. So that means that it's probably not a good marker to look at disease progression, but might be a great marker to look at the effect of a therapy, because you can predict that without a therapy, the SOD1 levels will be constant. Another potential pharmacodynamic marker, again in ALS as an example, is the presence of regulatory T cells measured directly or with a marker called FOXP3. And these are data suggesting that ALS patients have lower amounts of regulatory T cells in their peripheral blood compared to normal controls, and that rapidly progressing ALS patients have even lower numbers of regulatory T cells than those who are slow progressors. And the same kind of a response can be seen when you don't measure regulatory T cells directly, but simply measure FOXP3, which is a marker on Treg cells. And so potentially, if this is felt to be a pathogenic mechanism, the loss of regulatory T cell function, one could use this marker to see whether you're repairing the loss of Treg cells with a specific anti-inflammatory therapy. And then another fluid biomarker, again with relevance in ALS, but also in a number of other neurodegenerative diseases, is phosphorylated neurofilament heavy chain. This is basically dumped into the CSF whenever axons are damaged. And so it can be seen in traumatic brain injury, it can be seen in stroke, it can be seen in Parkinson's disease, Alzheimer's, and certainly ALS. And in ALS, you can see on the left-hand panel that there is a correlation of level of PNFH to disease duration and survival. So that the higher the level of neurofilament levels, the lower your survival time is. And then dividing people into tertiles of low, medium, and high NFH levels in the CSF at a given time of evaluation, you can predict survival and predict that survival is worst the highest your neurofilament levels are. Just like SOD1, however, neurofilament doesn't really change over time in patients, at least after diagnosis. So you can see on the bottom panel in B that slowly progressive ALS patients have lower levels of NFH, intermediate progressors have somewhat higher levels, faster progressors have somewhat higher levels, but for each group, the change over time is certainly not dramatic. So again, you wouldn't use a change in time of neurofilament as a prognostic marker, but you certainly could use change in neurofilament as a result of a therapeutic agent as a sign of activity of your agent. And so this is a marker that's being used more and more frequently now in phase 2 trials in ALS. Finally, in ALS, here is a PET marker. This is PBR28 as a ligand, and the goal is to look at microglial activation in ALS. Now, microglial activation has been shown to be abnormal in multiple sclerosis, in ADEM, and in a number of other inflammatory CNS diseases. And here you can see on the left-hand column, initially an ALS patient is shown in multiple cuts, and then a control patient in the next rightmost column. And you can see that there are areas that are intuitive in ALS, the prefrontal cortex, where there's increased activity, increased uptake of this PBR28 identifying microglial activation. And so whether this can be modifiable by an agent that changes inflammatory state in the brain is an important question, but might allow you to get an answer in a relatively small number of patients before you start looking at clinical endpoints. Using these kinds of pharmacodynamic endpoints as surrogates is something that's just starting in neurology, and multiple sclerosis has done this probably most effectively. This is a study of fumarate, the phase 2 study that didn't use disease progression as the outcome measure, but instead used new gadolinium-enhancing lesions. So they looked at 3 doses. They saw a clear dose response with 257 patients, which if you've read MS trials is actually quite small. And the data look like this, so that in a dose-related fashion, fumarate can reduce the number of new enhancing lesions over 6 months with an almost 70% reduction in the highest dose. This led to a phase 3 study, which used a clinical endpoint, which is relapse rate, and found that the pharmacodynamic marker was reproduced by clinical change with significantly more patients. So this is a 1,200 patient study now as compared to a 257 patient study. And so you can see that the use of that MRI marker was to identify a signal in many fewer patients, so that you could then go on and do your larger phase 3 trial with increased confidence. So moving to less laboratory-based and functional markers, they're often very useful in phase 2 and phase 3 studies. Here are some ones that are used in neuromuscular trials. I want to talk about strength a little bit, just because it is an example of how you have to think about the appropriate marker and measurement, even if you've decided what attribute you want to measure. So strength, you would think, was a pretty intuitive thing to measure, but it's not. If you remember how you do this in clinic with the MRC grading scale of 5 being normal and 0 being no activity, that measurement has been used in clinical trials, but it's a massively non-sensitive, non-linear test. And I'll show you an example of that. This is looking at the biceps, and the top scale is somebody who graded the biceps with the MRC grades from 0 to 5. And on the bottom scale are the actual force measured in newtons. And you can see that the difference in force going from 0 to 1 to 2 to 3, very, very small. And the difference from 3 to 4 is very large, and 4 to 5 is even larger. So that this is a scale that, even though you have five categories, most of the strength of a given muscle is in grade 4 and grade 5. And so you need a better way of measuring strength. We use quantitative muscle strength, and we train evaluators very carefully to use a handheld anemometer. And in that way, we can get linear declines in strength over time in diseases that have progressive weakness. In phase 3 trials, you need clinically relevant endpoints, and that's an NIH decision and an NIH definition. So what is a clinically relevant endpoint? Clinically relevant endpoint is a measurement of how a patient feels, functions, or survives. That's the entire definition. And clinical relevance is how patients feel, function, or survive. It can be completely subjective, or it can be objective in terms of measuring capacity. It can be survival, or it can be timed to a specific disease-related event. But it's often, even though it's a simple definition, deciding what's clinically relevant is somewhat fuzzy in some cases. For example, in a disease such as ALS, where patients lose strength, is strength clinically relevant? Well, so far the FDA has not been clear on this. They've made comments such as, well, we don't care how strong somebody is when you measure it with a dynamometer. We would care about how they walk across a room. And so you have to show us that kind of relevance when you think about strength. But these discussions are obviously still ongoing. Functional scales, and Dr. Adams talked about stroke scales, are clearly clinically relevant. They ask patients about their capacity. However, they're not always linear, and the extent of a difference in a rating scale isn't always obvious in terms of how clinically important it is. And there are many aspects of scaling that have been poorly attended to in the scales that we use today. And one issue is interval scaling. So in a NIH stroke scale, is the difference between a 10 and 11 the same as the difference between an 8 and a 9? Nobody's really paid attention to that. And so designing new scales is going to be important. But if you're going to do a study, you need to use a scale that's already been used before. Functional scales can be either disease-specific or attribute-specific. So quality of life scales can be applied across disease states, but the modified Rankin scale is a stroke scale. The EDSS is only appropriate for MS, and the ALS functional rating scale is only appropriate to ALS. And within a given scale, you can assess multiple properties of the disease. So, for example, the ALS functional rating scale assesses breathing, bulbar function, fine motor function, and gross motor function, all within the same scale. And so given that, it's often difficult when you see a change in a scale, say from 45 to 47 or 38 to 27, to know what that means in terms of what's happening to the patient as those different values are determined. Does it mean somebody is weaker in the arms, weaker in the legs? Does it mean they're having more trouble talking? Oftentimes you can't determine those kinds of issues just by looking at the value of a rating scale. Moving on to time to event endpoints, these can be time to an event as defined by a change in a functional rating scale. So you could say, I'm going to use as my primary endpoint the time for a change in the EDSS of 2 points. Or it can be a time to death, survival is a time to event. Or it can be time to a new hospitalization or time to a new stroke. All of those kinds of measurements are time to event endpoints, and they're clinically relevant because they assess functionally important characteristics. The advantage of using a time to event endpoint is that usually people can agree on when that endpoint has been reached. And so they're easy to understand. They're also easy to power for statisticians, so statisticians like them. But they have disadvantages too. And one is that really only subjects who have had an event contribute to your trial. So if you're looking at a fatal disease such as ALS and survival is your endpoint and it's your event, then only those patients who die contribute to that endpoint. The ones who survive really don't participate in the analysis in any useful way. And I'll show you an example of that in a minute. The other thing is if you use a non-death related endpoint, you can pick a time to a 5-point change in a rating scale, for example, but that means those patients who have changed by 3 points don't contribute to your endpoint either. So where you put your event is very important. Let's talk about survival, and here's two different survival curves for 2 different kinds of experiments. This again is ALS, and on the left is a set of survival curves for a treatment in mice where you follow all of the mice until they die. And so you can see that on the dotted line is a placebo treated set of mice, and the dark curves are treated with a treatment that's not terribly relevant. But what you can see is that there's about a 20-day survival difference in these mice. And if you did a statistical test, this would be highly statistically significant with a modest change in survival. And the reason that it's a and there are only 20 mice per group, so it's a 40 mouse study. The reason that you can see a modest change in survival in a relatively small study is that every single mouse had an event, so that every mouse contributed to the analysis. If you look at the data on the right, these are survival data that led to the approval of riluzole in 1996. And you can see that there are 3 doses, 50 milligrams, 100 milligrams, and 200 milligrams daily of riluzole. And the placebo curves of the change are identical in all three panels. And you can see that the difference in survival, number 1, depends on time, and number 2 is actually very small. So at 1 year of treatment, for example, the difference in survival is about 10%, which was about 30 patients difference in the riluzole treated patients versus the placebo patients. And the only reason that this was statistically significant was that 900 patients participated in this study. So that even in a fatal disease, a time to event endpoint is going to be very insensitive and will require a ton of patients if most patients don't reach the endpoint. So again, we talked about the different kinds of binary endpoints that you can use. Survival is obviously one. Hospital readmission, time to new stroke, time to initiation of a disease-related event, and for example, non-invasive ventilation in patients with ALS. If you have a treatment that is intended to cause improvement, then a binary endpoint could be time to achieving functional independence, or you're intending to improve ambulation, time to achieving independent ambulation, all of those would be useful kinds of binary events. So this is a really fast run through of a variety of different endpoints that can be used in clinical trials. And so when you're thinking about your own study, what's appropriate? What do you want to use? Dr. Adams made a plea for using a tried and true endpoint. And in terms of functional endpoints, I think that is by far the most conservative and by far the most sensible. But in earlier phase studies, and most of your studies are going to be early stage, you're not necessarily trying to make a decision of whether your intervention clearly works in the study that you're proposing in this course. You're much more interested in does it make sense? Is it reasonable? Does it pass the first stage? And the first stage is often the pharmacodynamics kind of stage, or even the pharmacokinetic stage, which is, does your drug get to where it needs to go? Does it have an effect on your target? And that can be measured with fluids, can be measured with imaging, and depending on your drug, depending on your disease, and depending on your target, a worthy goal for a study that somebody might do in this course is a pharmacodynamic marker study. And you may even use markers that you haven't completely defined the characteristics of. So there is a desperate need in virtually all fields of neurology for better pharmacodynamic markers, and those may be the subject of your studies that you're bringing forward to the course. No matter what you pick, what you need to know is, in later phase, certainly relevance to clinically important endpoints. But for all endpoints, new or old, you need to have some idea of the variability both in normal subjects and in your disease patients. And you need to have some idea of the sensitivity of changing this endpoint as a function of your intervention. And then if you're using a time to event or binary endpoint, you need to have an estimate of how many of your subjects will have an event in the time period of your study, because if it's not very many, you're not going to be able to successfully use that kind of endpoint. So in summary, the choice of endpoints is critical in the design of clinical trials at any stage. Endpoints need to be reliable. At later stages, they need to be clinically meaningful. And if you're going to use these endpoints as a clinical outcome measure, they need to be sensitive to your disease modification strategy. To choose endpoints appropriately is one of the critical tasks of a clinical trialist. And the correct choice of endpoint can really change your probability of success. And success, to me, is defined by making a correct decision, not by necessarily showing that your drug works. You need to be equally successful in showing your drug doesn't work. The currently available toolbox of measures in phase 2 is not adequate. And so we need new measures. And to do that, we need to know not just about how they change in disease states, but how variable they are, how they change over time without therapy. But the ability of finding these kinds of endpoints is likely to make our trials in all fields of neurology more efficient, more accurate, and more cost effective, and to bring therapies to patients much more quickly. So thank you, and I'll take questions.
Thank you, Dr. Shefner. Are there any questions or comments? I just want to point out in the chat box, the NINDS-CTMC website is there, as well as the FDA neurological endpoints for some diseases are covered in the guidances, and a link as well in the chat box.
I was going to ask a question for both of you. Given the non-interval nature of, say, the NIH stroke scale, which is like near and dear to my heart, what would be the way to correct? What would be the way that you could anticipate to correct for that? So it could be better used, I guess, more smoothly.
Sure, there's an easy correction readily available, frankly, Bill. It's very, well, how will we change it? What will we do? The more you start defining endpoints and nuances, the more difficult it became. And that's why we started out, believe it or not, the NIH stroke scale had 9 points for the motor, and we quickly abandoned it because it really became too complicated. One of the things that probably retrospectively we should have had in there was some measure of hand function, because that is so key. We don't. We just have the upper extremity, but we really had difficulty trying to define supplemental motor findings such as a hand or wrist.
And I
guess, oh, go ahead, Jeremy.
I was just going to say more in general. I'm certainly not a stroke expert, but more generally, all of the vast majority of these scales were developed by clinicians and not by psychometricians, and so virtually all of them are nonlinear. And so one question could be, how much do we care? Certainly, I think there are attributes of scales that we've been depending on for years where we should care. And so, a simple example is MRC grading, where all of your loss of strength is incorporated into one or two of the grades of strength, and so that it makes us unable to determine modest changes. And so, one change is to move to a continuous measurement, which therefore has interval scaling purposes. But the real way to do this is to sort of define your scales with psychometricians. I mean, so one of the things that you're teaching in your course is never design a trial without a statistician, because you're going to get yourself into boxes that you really can't get yourself out of. I think that in the future it might be equivalent to say, don't design a new scale without a psychometrician involved.
Yeah, no, those are good points. I guess I would just I was sort of thinking, are there ways you can sort of intervalize it? But as you're pointing out, you can have an NIH stroke scale of 0 from truncal ataxia, but be completely disabled. You're using it as a predictor of disability, basically, or as a sort of a proximate proxy for disability. And if you're a concert pianist, you can be disabled from hand weakness with an NIH stroke scale of 0. So it's important to come up with ways that you can, some of those are design issues, but then some of them are things like, can you at least use it as well as you can in its current state by orienting it towards a predicted probability of disability from existing and registry data, right? They all come with choices. It's not perfect. Your predicted disability is not 0 with an NIH stroke scale of 0. So it's and all of the different points. It depends on how you get the points. So it's very interesting.
I think it's very interesting, and it's true not just for stroke scales. It's true for other scales as well.
Right.
But another thing you want on scales is some sort of define as to what is good, what is bad, and what is really bad. And a scale that has 100 points, for example, how to define what's the significance of somebody getting a score of 88 versus somebody that gets a score of 95. Many of these scales have problems with both top and bottom, and it gets really also hard to make something. You want something that's clinically useful at the end.
I think at this point, though, we got to wrap up. And Joy, you want to close?
Sure. I'll email you the last question that we had. But I just want to make sure that everyone evaluates this webinar, and the link is in the chat. I just want to thank our presenters, Drs. Adams and Shefner, one more time. And if you do have any other questions or thoughts on the webinar, just email me and I will communicate that to our presenters. So thank you, everyone.
Thank you. Bye-bye.